This is Andrea, and we are talking about psychiatry. It is week 3 in HSC 114, medical terminology. We are moving right along, and this is Unit 16 in your syllabus. So if you're looking for what are we doing this week in terms of learning goals, learning objectives, that type of thing, make sure you take a look at Unit 16 in your syllabus for that. Pretty much we're going to do the same thing that we always do with every chapter, and lots to go over. We have over 60 slides, I think, on this one. So we will be zooming right through. All right. And I put this with the nervous system because we just finished talking about the brain and the spinal cord and nerves and how all of that happens. So this seems to go really well with that and pairing it. Not to mention that we're heading into the 4th of July weekend. And I'm sure a lot of you have wonderful plans and don't want to spend all day, every day. So these two chapters went together well and will work for this week. Psychiatry is the branch of medicine that deals with the diagnosis, treatment, and prevention of mental illness. Mental illness is no different than physical illness in the sense that a patient needs care. They need respect and they need treatment. Whether that treatment be medication-based or whether it be non-medication based, whether it be procedural, surgical, outpatient, there's a lot to that. Unfortunately, as you will find as you do your discussion questions for week 3, you may see that unfortunately there still is a stigma related to mental illness, which is really unfortunate because people with mental illness are like people with diabetes. You wouldn't tell a diabetic, oh, don't take insulin, or oh, don't go see a dietitian for advice or for ongoing consultation, or those types of things. And yet, unfortunately, there are some individuals in this world that look at mental illness in the same way. Oh, don't take a medicine. Oh, don't go see a doctor. Oh, don't go talk to a psychiatrist or a psychologist or a clinical psychologist. And yet, there's genuinely an illness there that needs to be addressed for the person's wholeness and wellness. So this is an area that we need to be super sensitive about and be respectful of. Many people who have mental illness have a hereditary or genetic component to it. And others have developed it over time. Maybe they've been in horrible, horrible home life situations, or maybe they've had some kind of traumatic or tragic or horrific life situation that has brought them to the point where they need some assistance. And so just as we would treat someone with a broken leg, or we would treat someone who had some kind of an accident that impacted their respiratory system, or any other system in the body, we need to be the same way here. What are some tools that are used by psychiatrists? They can use psychotherapy, psychoanalysis, or drug therapy. In addition to that, there are some others. They aren't mentioned here and they don't go into a lot of detail, but it's interesting to go out and research some of the cutting edge things that they're looking at for mental illness, whether it's prevention, whether it is better control, those types of things. There's a lot going on. And there's also, like I said, a genetic hereditary component that they're exploring through some different research methods. But today, typically, they look at psychotherapy, psychoanalysis, drug therapy. You may have also heard of ECT treatments, electroconvulsive therapy. That is another tool that can be used. What are some tools used by clinical psychologists? Psychotherapy, psychoanalysis, intelligence tests, mental processing tests, memory tests, personality tests. There's all sorts of different things that they can use. And we want them to have lots of tools in their toolbox, so to speak, to be able to tackle these illnesses and struggles and give people hope and give people ways and means that they can improve their life through their mental health. Psychiatric disorders really started being a field, so to speak, with Sigmund Freud's research, I suppose you would say. And it has grown since then. Originally, Sigmund Freud was thought to be the be all end all, the one who blazed the trail in mental illness. Since then, there's been a lot of others who have explored it and have enlarged the field and helped us to see more of it. And if you go back and you read a lot of Sigmund Freud's original information, you'll see it's really kind of primitive. And we've learned so much more about the human body and about genetics and about the different treatment options available for people, not just medication, but treatment options, um, that it really has gone far beyond there. But if you want to start at the beginning, you can look at the concepts of id, ego, and superego. And if you take a college level psych class, um, you will see that they go into a lot of detail about this and they'll talk about it. So I'm not going to cover it here, but that's something that you could research if this is an area of interest for you. And there's also a lot about defense mechanisms. I'm not going to get into that either, so we'll just move on. Some of the major disorders that are talked about in this area are anxiety, bipolar, depressive or depression, dissociative, eating, and neurocognitive disorders. There are also in this field, a lot of times substance abuse disorders get put in here. If you think about mental illness treatment, substance abuse is considered a part of that because a lot of patients with mental illness end up getting into substance abuse. And a lot of patients who have substance abuse issues may very well, and often do, have an associated mental illness. And the two kind of feed off each other. So as you get into the field, you find that those are often together. Anxiety disorders. These have tension, distress, troubled feelings, avoidance behaviors. They can be phobic, where you have a fear of something specific. They can be obsessive compulsive, where they're over and over repetitive, where you just find yourself doing the same things or thinking the same things. It's sort of like being that hamster on a little wheel. Can't quite seem to get off. It can be post-traumatic stress disorder. That unfortunately is something that a lot of our military people experience. They've been in horrible, horrible situations, and and they've been in it multiple times or for long periods of times, and so they end up with fear, insomnia, nightmares, those types of things. And if you go back in history and you study veterans of other wars, I mean, you could probably even go back to Revolutionary War time here in the United States, but definitely American Civil War, definitely Vietnam, definitely Korean War, World War II. I mean, really, you can pick any conflict, even the more modern ones, and post-traumatic stress is involved. People who have been through horrible, horrible situations in life have post-traumatic stress disorder. It is just an unfortunate side effect of going through something very, very, very stressful, shall we say. There is now something called generalized anxiety disorder, or GAD, GAD, and that's something where you have chronic anxiety, exaggerated worry, tension, even when there's little or nothing to provoke such feelings. It's just sort of it's something that's come over you. It's not specific like a phobic disorder, like a fear of heights. That may have happened to you and you realized, oh, I'm scared of heights. Maybe you took the elevator up in a very tall building and you got out and you looked over the railing and you thought, oh, I'm scared, I'm paralyzed, I can't do anything. That's a phobic disorder. That's something that's very specific. Or maybe you have something against spiders. I don't personally like spiders. They don't scare me to death. I mean, I can kill them. That's not a problem. But there are people that feel that way, but they get paralyzed. It haunts them, those types of things. Nothing wrong with that. Please understand, I'm not in any way judging any of these disorders. Just saying that it's very specific. A phobia is very specific. Obsessive compulsive is a fear that if you don't do something over and over and over again, that something bad is going to happen. It has that you have to do it. Oh, it's a pressure to do something over and over and over again. The post-traumatic stress is a reaction to a really bad situation, whether it happened one time or many times, or whether it was over a long period of time or just short, repetitive periods of time. It's something that has really traumatized the person, and these things come back to them. And then the generalized anxiety disorder. Well, let's talk about bipolar. Bipolar. There's two different poles when you think about it. You're between two extremes in a way. It is prolonged emotion that dominates a person's entire mental life. So there are types of bipolar disorder. Understand that there's bipolar type 1, bipolar type 2, those types of things. Bipolar, as we typically think of it, is type 1. And that's alternating between being very manic and very depressed. It's those peaks and valleys. It is manic, being top of the world and just feeling full of life and active and all these other things to an extreme. And then you have all of a sudden the exact opposite, where it's just awful and life is awful and it's just miserable and can barely function. And bipolar is going back and forth between those. Now, it may be happening quickly. It may be happening maybe over a period of several months. And it's just that there's these highs, these super highs, and these super lows. And there is definitely a hereditary component to bipolar, so just be aware of that. Bipolar type 2 is where somebody is very depressed and then they're essentially kind of lesser depressed, and they go back and forth between being very depressed and being lesser depressed, but they're not above that sort of normal line. They're not getting up into the manics. Then you have cyclothymic disorder. That's mild bipolar, where that's sort of the type 2 I was talking about, is where it's more below. You're not getting into the manics. Depressive disorder, you may have heard of major depression disorder, severe dysphoria, those types of things. That's more of where you go through periods of being normal, but then you go through periods of being really depressed. So you've got those types. Depressive disorders, that's really a prolonged emotion that dominates a person's entire mental life, where they're very, very depressed. And depressed encompasses a lot of things. Being sad, being unhappy, being not wanting to be around people. You can really look up all of these, and they have a lot more information, but you just need to know what they are. Dissociative, if you think about that, if you think about the word dissociative, what comes to mind? Think about associative. Associative means you like to be with people, you like to associate. There's a similarity, there's a comfort, there's a ability, there's relationship, those types of things. Disassociative is sort of like a disturbance from that. There's a disassociation, a pulling away. So let's talk about that in terms of mental illness. It's a chronic or sudden disturbance of memory, identity, consciousness, or perception of the environment that's not caused by brain damage or drugs. So that's a mental disorder. It can be that you have personalities that take over. It can be that you have a loss of memory. Again, not caused by Alzheimer's or some type of brain damage, not caused by using some kind of likely illegal drug. It is, these things just happen. Dissociative fugue is sudden unexpected travel. These are all things that just happen. They may happen over time, they may be sudden, they may have peaks and valleys to them, but there's that disturbance, that disassociation between memory, identity, consciousness, perception of the environment. Eating disorders, the two main ones that the mental illness field really focuses on is anorexia nervosa and bulimia. And I'm not really going to go into either one except to say that there are some associations there. These have the potential to really hurt someone physically and mentally, emotionally. They're very wearing on the body and on the mind. And so it's really important that if someone is struggling with these, that they get help, and that the treatment be consistent. And these very well may be lifelong struggles for people. So definitely an eating disorder is something to take very seriously and to get the help that's needed, to encourage, to find ways to get treatment and make that work. Neurocognitive disorders. This is disorders of abnormal cognition, thinking, perception, reasoning, or judgment. These have a nerve component to them, a nervous system component to them. Think of the word neurocognitive, cognitive being mind and neuro being nerves. So delirium. Delirium is mental confusion, incoherent speech, sensory misperception, disorientation, memory impairment. People can develop delirium from extreme infection. People with sepsis sometimes have delirium. People who are withdrawing from a drug may have some delirium. There are different reasons that this can happen, but it really impacts, and it's a situation where their cognition is being impaired because of something that's going on in the body. Dementia is another example of where there's a loss of those intellectual abilities. And dementia can come about just from aging. It can come about from an actual disease like Alzheimer's. It can come about from something else that happens in terms of an injury, those types of things. So just keep that in mind. What are some neurodevelopmental disorders? Now, we studied about sort of congenital nervous disorders in our last one, and we talked about like spinal bifida and things like that. These are often found to be genetic as well, that there might be a hereditary component, or there might be an how a gene acts out its genetic components can go wrong. Intellectual disabilities. It could have been something that developed when a child was in the mother's uterus and it was developing. It could be something that is environmental. You've heard of lead poisoning and different other things that can happen that can impact someone's intellect and cause a disability. Communication disorders, blindness, hearing loss or impairment, speech issues, understanding, and that's all things that involve the nervous system, but can also involve the cognition and can also happen through either genetics hereditary inheritance of something with genetics, or through the environment, or through an injury. A traumatic brain injury sometimes causes an intellectual disability in someone, or a communication disorder. Then you have the autistic spectrum disorders that have been growing in terms of research over the last 20 years. Attention deficit hyperactivity disorders. There are specific learning disorders. Some people have challenges with memorization. Others have, you can think of dyslexia as a specific learning disorder that people, it's a challenge they have to overcome. And then there's motor disorders. Sometimes our bodies don't work quite the way they're supposed to. Maybe there's something going on and they can't move, or maybe they've got cerebral palsy or something like that. Personality disorders are another form of mental illness that are kind of put into this group to be studied and diagnosed and treated, those types of things. A personality disorder is an enduring pattern of thinking and behavior which is contrary to what is culturally acceptable. Now, it's interesting for us to think about what is culturally acceptable and how that has changed over time. Things that are labeled personality disorders now may not be labeled personality disorders in the future, depending on that culturally acceptable definition. So just kind of be aware that personality disorders are a bit fluid. What they were considered 50 years ago versus what they may be considered another 50 years ago might change. But it's pervasive and inflexible, usually has an has an onset in early adulthood and leads to distress or conflict with others. So personality disorders are considered something that is pervasive and inflexible, often starts in early adulthood, and leads to distress or conflict with others. And it is usually an enduring pattern of thinking and behavior. They are currently divided into 3 cluster categories: paranoid, schizoid, and schizotypal. And that's cluster A. If you've ever heard of paranoid schizophrenia, that might be an example of a personality disorder. And many people who have schizophrenia have been on medication and are perfectly fine, and you would never know it to talk to them that they struggle with that disorder. And others, they struggle to take the medication, or they don't take the medication at all, and then you see the personality disorder clearly through their life, through that conflict that it was mentioned on the last slide. Cluster B, antisocial behaviors, borderline, histrionic, and narcissistic. Histrionic is a beautiful word that means dramatic. And not everyone who's dramatic has a personality disorder. Some people are just more dramatic than others. And then there are other people whose drama ends up causing that conflict, and it is pervasive instead of just maybe occasionally situational. So again, you kind of have to take with a grain of salt that these are personality disorders and how they're come up with and that sort of thing. Narcissistic is, there's an old myth about this. You can look up Narcissus and get the myth about this, but basically it means love of self. It means thinking that you are the most beautiful, most wonderful. It's really thinking about yourself as the center of the world, the center of everything, and everything is all about you, and that type of thing. And there are people who do struggle with that, whether that is something that, again, is found to be hereditary or genetic or environmental. Maybe they were raised to be that, maybe that was the situation. But again, what are the outcomes? How does it impact the person? How does it impact their ability to live? What kind of treatments are available? And that's what needs to be focused on. Cluster C, avoidant, dependent, obsessive compulsive. And we talked a little bit about obsessive compulsive before. Schizophrenia, other psychotic disorders, these are usually characterized by disturbed thinking and disorganized speech. They may have delusions or hallucinations where they see things or hear things that others don't. They may have a very flat affect, meaning that they don't show emotion. They seem very cold, very self-contained, very just not there. They're just not there. And that is not intentional on their part. That is simply a symptom of the disorder that they have. And sometimes the medication that someone may be on for something like that may exaggerate that a little bit more or not address that. So just be aware that if you're interacting with someone who has some type of a disorder and you notice that they have a flat affect, please do not take that personally. That may very well be something out of their control that's part of their disorder. They may have an unwillingness to initiate purposeful activities, whether there's a fear behind that, whether there's a lack of motivation behind that, whether there's truly something chemical behind that that inhibits that. You know, we talked about neurotransmitters. Maybe there's a chemical issue there of too much of something or not enough of something, or there's some kind of activity or something blocking that. So just keep that in mind. Somatic symptom disorders, these are conversion and illness anxiety disorders. A conversion disorder is where repressed conflicts are expressed as physical symptoms. Think about that, converting. You convert it from mental, emotional into physical. So let's say that someone has some issues going on, some mental issues going on, and they're expressing that by being very angry. That could be a type of a situation. You know, sometimes people have said that depression can come out as being anger. They may have some issues or something going on there that's being expressed physically. It can also mean not just as anger or as a situation, but maybe they've got headaches. They genuinely have headaches. They're not migraines, but they have these headaches, and in tracing them back, they're clenching their teeth. They're so tense from these repressed conflicts going on that it's coming out converted into physical symptoms. Illness anxiety disorder, that is where you get into some of these situations where people are preoccupied with having or acquiring a serious illness. They can be doing it for a multitude of reasons. That can be attention, it makes them feel good, it makes, whatever's happening. Some type of significant disruption in life is a result of conversion or illness anxiety. And that's where help is needed to get them back on track. And I talked a little bit about substance related and addictive disorders. There are a lot of times that mental health and substance abuse are related. I've worked in numerous health facilities with behavioral health inpatient units. And I have done a lot of chart reviews. I have looked at physician documentation for a number of reasons. And one of the things that I have come away with is just there's such a link there that when there is a mental illness, there is a much higher risk for substance abuse. And if you trace back in substance abuse, oftentimes there is an underlying mental illness there that's untreated or undertreated that needs to be addressed so that the person truly can break away from the substance abuse situation. So there needs to be a lot of compassion in working with patients who have substance abuse types of things or addictive disorders, because oftentimes you will find that there's something else going on there, and that there very well may be a hereditary component or some type of genetic, whether that's inherited or environmental, that has occurred. So what is psychological dependence? It's when you have a compulsion to take something despite its adverse consequences. Mentally, you just feel like you've got to take it. You just got to do it. Physiologic dependence is when the drug is your body's dependent upon that drug. So psychological is when your mind says, we've got to take this, we've got to do this, we've got to eat this or drink this or take this. Physiological dependence is when your body is saying, if you take this away from me, you're going to have physical problems because of it. You may have a high heart rate, you may have hallucinations, you may have tremors, you may have vomiting, you may have headaches, you may have confusion, you may have, those are all physiologic dependence type situations. And psychologic is your mind saying, I got to have this, I've got to have this. In order to do this, I've got to have this. And so both have to be addressed if you're dealing with this type of situation. Tolerance is how much of an effect of a drug you can handle, and how over time the effect of a drug will decrease, so the dose has to increase. So let's say someone is on a medication for, say, I don't know, we'll pick depression or anxiety. You're on that medication, and over time your body gets used to it. And the effect of that medication may fade over time to be less than what it was because your body's gotten used to it. And so it doesn't have the same effect anymore. So sometimes you find that after you've been on a medication for a year or 5 years or whatever your time frame is, that the effect isn't quite as good as it was, and therefore your dose might have to be increased. And it's not just with mental illnesses that this can happen with. It can happen with if you are taking a thyroid replacement medication. Let's say you had to have your thyroid removed for whatever reason. And so you're taking a thyroid replacement medication. That effect may change over time with your body. And so your dose may have to increase, or it may have to decrease. And that's what tolerance is about. So what are some substances associated with abuse? There's alcohol, amphetamines, cannabis, which is also known as marijuana, cocaine, hallucinogens, opioids, sedatives, hypnotics, and I really can't talk today. Anxiolytics instead of anxiety, anxiolytics. All right, so we're almost done. Hang in there. We're moving along. Therapeutic modalities. There's psychotherapy, there's ECT, and there's drug therapy. I talked a little bit about ECT earlier, electroconvulsive therapy. That's coming back. That was used a lot in the 70s and 80s. Then it wasn't used. Well, I guess it was 60s and 70s mostly. And then it fell out of favor for the 80s, 90s, and early 2000s. And now it's starting to come back in certain uses. And then there's drug therapy. So psychotherapy, cognitive behavioral therapy, family therapy, group therapy, hypnosis, insight-oriented psychotherapy, play therapy, psychoanalysis, there's sex therapy, supportive psychotherapy, there's all sorts of stuff. And then you get into your drug therapies and the specific drugs. This is a really good example slide where it talks about the disorder, and then it gives you some examples. And then from there, it can talk about it. So vocabulary, I'm going to try and fly through these, so you may have to hit pause if you really want to look through these. Just again, these are terms that you'll see in your book, and also that you may have seen in the slides and their meanings. Not much to say about these. Just hang on. I'm going to fly through them. And so there's just a lot to this, but you can see how it dovetails well with Chapter 10 on the nervous system. And so that's why those two are together. Psychologists are not usually MDs. If you're an MD, you're usually a psychiatrist. Psychologists usually have a master's degree. And here are more vocabulary words for you and their meanings, and this is getting more into the therapy side of life. Benzodiazepines, those are drugs that lessen anxiety, tension, agitation, panic attacks. Tricyclic antidepressants, those are used to treat severe depression. You see the cycle word there, circling through. Abbreviations, lots and lots of abbreviations. And now we get it to our combining forms. Remember, we've got our combining root plus our combining vowel, which equals our combining form, and then the meaning. And then, of course, we've got some suffixes here for you. And, of course, a few prefixes. So quick quizzes, fear of strangers. You might have to go back and look that up. We didn't really talk about that. Talked about this a little bit, so that one should be a really easy one for you to answer. Talked a little bit about this too. And that is it. So I hope you're doing well. I hope you have a wonderful 4th of July. Look forward to talking to you next about the urinary system and male and female reproductive systems. So that'll be week 4, something to look forward to. We are flying through these body systems, so hang in there. Take care.